Now next one is Stone's index, which is given by H. Stone in the year 1949. It is for decay teeth, and it has D1, D2, D3, D4. It mainly calculates the decay of the tooth, in which we have smooth surface and pit and fissure. In smooth surface, we have white opaque area with loss of luster. D2, we have slightly discontinuity in enamel. Third, we have dentine involvement. And fourth, we have pulp involvement. And in pit and fissure, we have discoloration, all confined to a small narrow line, no definite sticking. In D2, we have slightly discontinuity in enamel, sticky fissure with or without discoloration. The probe requires a definite pull for removal. In D3, we have dentine involvement. In pit and fissure, we have definite cavity with dentine involvement. In D4, we have pulp involvement. Next, we have scoring criteria 1, 2, 3. Criteria, we have one or more cavities in the same tooth respective to enamel. 2, we have one or more cavities in the same tooth with dentine involvement. 3, we have one or more cavities in same tooth resulting in a total destruction of more than a quarter of the crown. So this is the criteria of indices. Sorry for disturbance. Next one is the Czechoslovakian index. So Czechoslovakian index is also known as Czechoslovakian Caries Index, which is given by Ponsova and Matina in the year 1956. It is used to compare experience in one group with that of other groups with a similar population density but living in different environments. In this index, variable seems to be controlled. The average number of teeth or teeth surfaces and tooth areas and conditions of previously extracted or crown teeth are considered. So, this is the formula of Caries index. So, it is equal to 1 minus C minus FC is filling in crown by 4 by 5E, that is extraction, 2 by 3 that is anchorage teeth. एंकरेज टीथ मीन्स जो भी टीथ को हम एंकरेज के लिए मोस्ट ऑफ द टाइम हम मोलर्स को जैसे एंकरेज के लिए हम लेते हैं ऑर्थोडोंटिक ट्रीटमेंट्स में, तो दैट इज एंकरेज टीथ. सो बेसिस का क्या हुआ फॉर इंडिविजुअल एग्जामिनेशन अमाउंट ऑफ टीथ इन एडल्ट एग्जामिनेशन दैट इज 32. In collective studies, number of person examined into 32. Average index value 0 to 1. If caries index is 1, then the caries frequency is noted as high. Next one is the caries severity index. So caries severity index is given in the year 1986 by Aubrey Cossack. Caries severity for primary teeth based on clinical examination only. It gives information in children to DEF figures, especially when investigating preventive measures. It is this index is a way to measure how severe tooth decay is in a group of people. There is one also important caries severity index, which is known as Billings root surface caries severity index, which can be asked sometime. So This classifies as Billings root to surface caries severity index classifies regarding the incipient, shallow, cavitated, or with caries with the pulpal involvement. And scores of each carious surface of the tooth, and then averages the scores of all affected teeth. Now this is the scoring. First we have occlusal surface and pit and fissure caries and on buccal or palatal surface on molars. So we have score 1, which says that early pit and fissure caries when the explorer catches. ऑलवेज रिमेंबर हम यहाँ पे सारे जो इंस्ट्रूमेंट हमने यूज किए हैं वो हमने माउथ मिरर और एक्सप्लोरर यूज किए हैं. केरीज सिवियरिटी में मैंने दो चीज बताई. एक तो ये कि इसमें एक बिलिंग्स रूट सरफेस केरीज इंडेक्स है. अब ये जो हमें उसका डिस्क्रिप्शन जो ऑक्लूजल सरफेस पे पिट एंड फिशर केरीज है जो बक्कल और पैलेटल सरफेस ऑफ मोलर्स पे ये उसके हैं. इसमें अलग अलग हमारे जो है वो डिस्क्रिप्शंस हैं जो मैं आगे बताऊंगी. ये भी ऑक्लूजल सरफेस के हैं. सो वन में हमारा है पिट एंड फिशर केरीज व्हेन वेयर द एक्सप्लोरर कैचेस और रेजिस्ट रिमूवल विथ मॉडरेट टू फर्म प्रेशर and is accompanied by either softness at the base of the area or an opacity adjacent to pit or fissure as evidence of undermining or demineralization or softened enamel adjacent to the pit or fissure which may be scraped away with the explorer. Second में हमारा है cavitation of at least 1 mm across the smallest diameter at the tooth surface. Third, we have cavitation with breakdown or undermining as seen by obvious discoloration of at least half of a cusp. This is for buccal, lingual and palatal smooth surface. So इसका description है 1 score है तो a whitish lesion not extending to the embrasure areas found to be soft and sticky by penetration with the explorer. Second में cavitation of at least 1 mm but 2 mm across smallest less than 2 mm across smallest diameter or a soft sticky white lesion extending into one embrasure. In third one we have cavitation of at least 2 mm is the smallest diameter or a soft sticky white lesion extending into the both embrasure. C we have proximal surface of molar. The scoring we have 1 discontinuity of enamel in which an explorer which catch and there is softness. In 2 we have cavitation with early breakdown of the marginal ridge or obvious discoloration indicating undermining the ridge. 3 we have breakdown of the marginal ridge with cavitation extending to the medial or distant extension of the occlusal surface. This is for proximal surface on incisor and canine. In 1 we have a discontinuity of the enamel in which an explorer will catch and if there is softness. Second, we have cavitation with breakdown or obvious discoloration indicating undermining for at least 1 mm on the buccal and lingual surfaces. In 3, we have cavitation with breakdown of the incisal edge or undermining of the edge as indicated by obvious discoloration. Now, how to calculate caries on buccal, lingual and palatal surface in all teeth continuous with occlusal or proximal caries is only scored for these surfaces when normal pit or fissure of these surfaces are affected or included or when caries extend along at least half the gingival third of these surfaces. Only the largest caries involvement is scored for any one surface. Scores of 2 or more lesions on one surface are not combined. Filled surface we will score 1 and secondary caries at the margin of restoration score 2. Now caries susceptibility index. It is given by Richardson A in the year 1961 and this index is based on Boker and Melny caries indices. These are two factors involved in measuring caries susceptibility using the dynamic survey, namely amount of tooth surface at risk, amount of caries developing during period of observation, and caries susceptibility is equal to B by A. So one thing that I want to say is जो the caries susceptibility can be measured using a variety of dental indices including DMFT index, DEFT index, and the caries severity index. So these indices can be used to assess the dental health of a population or as well as or an individual. So how what is the method of uh, recording caries severity index? Each tooth is divided into various surfaces. To use one caries tooth surface as the unit of measurement, susceptible surface are scored as follows. And incisors and canine 4 surfaces, मोलर में 5 surfaces. तो परमानेंट में हो गए आपके 148, प्राइमरी में हो गए हमारे 88. प्राइमरी में हमारे हम काउंट करते ABCDE, और यहाँ हमने मोलर से 5 सरफेसेस लिए हैं जैसे कि मैंने DMFS में बताए थे. 4 सरफेस हमने कैनाइन तक लिए थे, बाकी जो प्रीमोलर से लेकर के मोलर था हमने 5 सरफेस लिए थे. बिल्कुल उसी तरह हम यहाँ भी मेजर करेंगे. Each individual examined initially for tooth surface with caries and restored surfaces are noted. Each individual is re-examined after observation period for of 6 months and 12 months. New carious lesion on any soft surface noted previously, restored surfaces and initiation of carious lesion are checked and noted. Number of susceptible surfaces calculated from initial examination. Tooth that is caries free are not restored in considered susceptible. So susceptibility ratio is equal to number of caries surface developed during period of observation by number of susceptible surface determined in the first inspection or initial examination. So susceptibility index is equal to susceptibility into 100. सो सब्सेप्टिबिलिटी से ही हमें समझ आ रहा है कि कौन सी टीथ को सबसे ज्यादा मतलब चांसेस हैं केरीज होने के. स्पेशली हम उस चीज पे फोकस कर रहे हैं इस इंडेक्स पे. नेक्स्ट इज मोलर्स इंडेक्स. सो मोलर्स इंडेक्स इज डेवलप्ड बाय मोलर आईजे एंड पॉल्सन इन द ईयर 1966, and it is a standardizing system for diagnosing, recording, and analyzing dental caries. Scoring criteria is specified for pit and fissure sealants, smooth surfaces, radiographic evaluations of proximal caries, and this is the scoring of the molars index. Code 0 for pit and fissure sealants, sound normal, and for vestibular and lingual smooth surface, sound normal is 0. Proximal surface, enamel surface, contour distinct and unbroken is 0. Discoloration, no definite sticking is 1 for pit and fissure. White opaque area with loss of luster, no loss of substance, 1 for vestibular and smooth surface. And for proximal surface, enamel surface, contour is broken, a shadow between the enamel surface and the border not more than 1/4 through the enamel. 2 for pit and fissure, sticking with or without discoloration, no dentin involvement is 2. Discontinuity in the enamel, loss of substance, no dentin involvement for vestibular and lingual smooth surface is for 2. And for proximal surface, we have shadow has reached dentino-enamel junction. In code 3, for pit and fissure, we have definite cavity with dentine involvement. For vestibular and lingual smooth surface, dentine involvement. For proximal surface, a shadow between the dentino-enamel junction (DEJ) and broader, not more than halfway through the dentine. In 4, for pit and fissure, probable pulp complication in vestibular and lingual smooth surface, probable pulp complication, and in proximal also shadow more than halfway through the dentine. So this is the diagnostic criteria and respective coding. Now, what equipment we used here? We record using a plane mirror and standardized dental probe. Each probe should be used for once. After that, it is sent for re-standardization. Dental examination, dental chair, operating light source, pre-cleaning of teeth, isolation with cotton rolls, saliva ejector, and drying with compressor air is recommended. Radiographic examination, standardized procedure, exposure development, and diagnosis of radiograph should be carried out in standardized condition. Now, the procedure, all teeth are examined except third molar. A tooth is erupted when any part of it projects through gingiva. Canine and incisors के 4 surface, primary molar 5 surface. Primary teeth are examined same as permanent teeth. So the scoring criteria is 0, 1, 2, 3, 4, 5, 6, 7, 8, 9. 0 is sound, 1 type 1 caries, 2 type 2 caries, 3 type 3 caries, 4 type 4 caries, 5 filled tooth, 6 missing due to caries, 7 tooth or tooth surface not erupted, 8 missing tooth for reason other than caries, and 9 congenitally missing and non-recordable. Now the Nevitt's index. It is proposed by Nevitt in the year 1999, and this is based on the visual caries tactile classification to enable the detection of activity and severity of caries lesion, which specially focus on the low caries population. Useful both in clinical practice and in research setting. The caries process. One thing we have to remember in Nevitt's index that the caries process at surface or tooth level is classified into 9 stages, and each severity stage from clinically sound surface through teeth, non-cavitated and microcavitated caries lesion in navel to frank cavitation to dentine that can be classified in double way as active or inactive. So must this thing have to remember in Nevitt's index. So the criteria behind the classification reflect the entire continuum of caries ranging from clinically sound surfaces through non-cavitated and microcavitated caries lesions in enamel to frank cavitation to the dentine. Unique feature of this classification is assessing the severity of lesion, presence or absence of cavitation, and each severity includes an assessment of lesion activity. Active may surface is matte, rough on gentle probing with sharp explorer. Inactive, shiny and smooth on gentle probing. So the description of Nevitt's criteria for caries lesion activity and severity index, which is given in the year 1999, sorry. So instrument used are sharp explorer, not ball end or plastic explorer, no tactile feel. So this has 0 sound, normal enamel translucency and texture, 1 active caries, 2 active caries, 3 surface discontinuity. In 3 we have active caries cavity, 4 we have active caries intact surface, 5 we have active caries surface discontinuity, 6 we have active caries cavity, 7 we have filling sound surface, 8 we have filling plus active caries, 9 we have filling plus inactive caries. And these are the criteria for the Nevitt's caries. What are the advantages of Nevitt's index? Can identify incipient caries lesion, hence can be used for planning preventive programs. Underestimation of prevalence and severity of caries with DEF index can be omitted as it measures only cavitation state. Reduce the need of treatment on long-term basis because diagnosis of initial lesion can stop the progression of lesion. What is the disadvantage? It is difficult to make exact diagnosis of precavitated active lesion over occlusal surface than facial surface. Psychological wear of occlusal surface during mastication can lead to disappearance of lesion. Now, significant caries index, which is given by Dolores Brethal in the year 2000. Significant caries index is not a new index, rather a form of data presentation to help uh, give a better picture of distribution in population in order to bring attention to those individuals with highest caries score in each population, more significant in population where caries prevalence is low and has a skewed distribution. So SIC जो index है, it is used to measure of oral health that focuses on the highest caries scores in the population. It can help addresses problem with uneven distribution of caries. Second thing, and it is used to measure the future oral health goals. Another thing is it can help solve problems with skewed caries distribution. Third one is it can be used to compare the capability of two indices for preventive and prognostic goals. So how we calculate SIC? So first we sort individuals by their DMFT values, then select the top one third of the population with the highest caries scores, then we calculate the DMFT for these subgroups and then use the DMFT as the SIC index. Now the new goal for oral health. The following oral health goal is proposed that the significant caries index should not be less than 3 DMFT in 12 years old. Burst proposed 3-level model. Basis should be population to reduce overall caries level. Geographical areas with high level of caries is given extra attention and attention to high risk individuals. What are the advantages of this index? It is used along with the DMFT index used to assess caries prevalence globally. More focuses on neglected and needy group. Effective early preventive measures can be taken. The disadvantage is if only SIC is used, it leads to lack of information regarding severity of disease, especially in areas where incidence of caries is still present. Now, specific caries index given by Shashidhar Acharya in the year 2006 to provide a reproducible surface specific caries index that would provide qualitative and quantitative information about untreated caries, dental caries in individuals based on clinical examination. The DMF index gives information about the specific surface involved but do not provide any additional details about the exact location on the particular surface. Criteria for this index is based on GB Black classification. This is the score and description. 0 is no caries lesion detected. 1 caries lesion occurring on occlusal buccal pit and fissure of molars and premolars and the lingual pits of anterior teeth. 2. Proximal caries affecting the molars and premolars. 3. Carious lesion situated on the proximal surface of the anteriors and not involving the incisal angle. 4. Carious lesion situated on the proximal surface of anteriors involving the incisal angle. 5. Carious lesion situated on the cervical region of the tooth. 6. Carious lesion situated on the occlusal cusp tips of molars and premolars and on the incisal edges of incisors. 6a. Grossly decayed teeth root stumps indicated for extraction. What are the advantages of this index? It provides information on caries prevalence, location, and type of caries lesion in an individual based on clinical examination. Criteria are simple and easy to use. Reproducibility is fair to good. The disadvantages are large lesions covering one surface. Only assumptions can be made regarding originating lesions. Inability of index is used alone to capture information useful for treatment planning. Lack of provision for assessing root caries. Now, international caries detection and assessment need. So ICDAS detection codes for coronal caries range from 0 to 6 depending on the severity of the lesion. These are minor variations between the visual signs associated with each code depending on a number of factors, including the surface characteristics, fit and fissure versus free smooth surface, whether there are adjacent teeth present, mesial and distal surface, and whether or not the caries is associated with restoration and sealants. And this ICDS scoring system, it is a clinical scoring system for use in dental education, clinical practice, research, and epidemiology. Uh, it is a detailed descriptions of each of the codes is given under the following heading to assist in the training of examination in the use of ICDAS. First is fit and fissure, second is smooth surface, medial and distal surface, third is free smooth surface, and four is caries associated with restoration and sealants. This index was developed to bring forward the current understanding of the process of initiation and progression of the dental caries to the field of epidemiological and clinical research. And this one thing we have to remember, this system allows us to record the severity and incidence of caries in its continuum. And there are two ICDS. The ICDS one was developed in the year 2002 and was later modified to ICDS in 2005. The ICDS 1 and 2 criteria incorporate concepts from the research conducted by Strand et al. In the year 1995 and 1997. And the other caries detection system described in a systematic review, which is conducted by Ismail et al. In the year 2004. So this is the description. 0, 1, 2, 3, 4, 5, 6. 0 is sound, 1 is visual, first visual change in enamel, 2 is distinct visual change in enamel, third is localized enamel breakdown, 4 is underlying dark shadow from dentine, 5 is distinct cavity with visible dentine, 6 is extensive distinct cavity with visible dentine. This is also any caries discoloration. If yes, is there cavitation? In cavitation, we have no, yes. If no, is there shadowing? If yes, is dentine exposed? In no, we have yes or no. No extends beyond pit and fissure. No, yes. Then in yes, is dentine exposed? Yes, more than one half total surface involved. Then no or yes. So this is caries associated with restorations and sealant. Cards detection criteria. So this is codes. We have 0 smooth surface with restoration of sealant. In 1 we have first visual change in enamel, second we have distinct visual change in enamel, dentine adjacent to restoration or sealant or margin. In 3 we have carious defects of 0.5 mm with the signs of code 2. 4 we have marginal caries in enamel and dentine, cementum adjacent to restoration, sealant with underlying dark shadow from dentine. 5 we have distinct cavity adjacent to restoration or sealant. 6 we have extensive distinct cavity with enamel or dentine. This is the ICDS 2-digit coding method. A 2-number coding system is suggested to identify restoration sealants with first digit followed by the appropriate caries code. It also have codes and description. 0 we have sound surface not restored or sealed. 1 we have sealant partial. 2 we have sealant full. 3 we have tooth colored restorations. 4 we have amalgam restoration. 5 we have Stainless steel crown. 6 we have porcelain or gold or PFM crown or veneer. 7 we have lost or broken restoration. 8 we have temporary restoration. 9 we have used for following conditions. 9.6 we have tooth surface examined, cannot be examined, surface excluded. And 9.7 we have tooth missing due to caries. 9.8 we have tooth missing for reason other than caries, and 9.9 is unerupted. Now, a universal visual scoring system given by Jan Niche et al. In the year 2009 recently introduced diagnostic system like Naivet's Index, ICDAS 1 and 2 have included non-cavitated caries lesion but classifies the caries process with only by few criteria. The ICDAS2 criteria do not longer distinguish between white and brown discoloration, which is fact provide important information about the lesion cavity activity. New visual caries detection and diagnostic system on the most caries susceptible sites. It can be examined at field level, clinical and laboratory level. So the instrument used are dental mirror and CPI probe. So in field study type, we use cotton rolls, headlamp, and tooth cleaning, patient brushed him या herself. In clinical, magnifying glass, loop, examination lamp, professional tooth cleaning with a bristle, brush, etc. In third laboratory, we have dental unit with air syringe, operating light of the dental unit, professional tooth cleaning with air polishing. So this is the criteria for universal visual scoring system of Pitt and Fisher. These are the occlusal surfaces. We can see score 1 white. So first visible sign of caries lesion, and this is the established caries lesion. Here we have microcavity. Here dentine is exposed. Here is a large cavity, and here pulp is exposed. In score 2 white brown, then here we can see established caries lesion. Here we can see the microcavity. Here we can see the dentine exposure. Here we can see the large cavity, and here the pulp exposure can be seen. Here we can see the dark brown. Here established caries lesion can be seen. Here microcavity and enamel breakdown can be seen. Here dentine exposure can be seen. Here large cavity can be seen, and pulp involvement. Grease translucency, established caries, microcavity, and dentine exposure. Now this is this is for the proximal area. So here, this is for the smooth surface. White score 1, first visible sign of caries lesion. Second one is the established caries lesion. Third one is the microcavity. Here we can see the dentine exposure, and here we can see the large cavity. Second one is the white brown. Then in here, established caries lesion. Here we can see the microcavity. Here we can see the dentine exposure. Here we can see the large cavity, and here pulp exposure. Here we see a dark brown cavity. This is established caries lesion. Here microcavity, dentine exposure, and large cavity. What are the advantages? So entire spectrum of non-cavitated caries lesion on the occlusal and smooth surface with just one visual diagnostic system. Preventive and therapeutic procedures can be used in field, clinical, and laboratory. Disadvantage: more time consuming, more effort, teeth to be cleaned prior to examination. Now PUFA index, pulpal ulceration fistula abscess index, which is given by Monsby et al. In the year 2010. Clinical consequences of untreated dental caries, pulpal fistula abscess ulcerations. Assess the prevalence of these untreated caries, PUFA index. Lesions in surrounding tissue that are not related to the tooth with the visible pulpal involvement as a restored caries are not recorded. Assessment is not made visually without use of any instrument. Only one score is assigned per tooth. In case of doubt concerning the extent of odontogenic infection, the basic score is given. The primary tooth and its permanent successor tooth are present and both present stages of odontogenic infection. Both teeth will be scored. Uppercase is permanent and lowercase is primary. So this is PUFA index. So PP, that is permanent and primary pulpal involvement, is recorded when the opening of the pulp chamber is visible and when the coronal tooth structures are being destroyed by the caries process and the roots or root fragments are left. No probing is performed to diagnose pulpal involvement. Here we can see these things in the picture. Now U by U, upper by lowercase, ulceration due to trauma from sharp pieces of tooth. These are the sharp pieces of tooth. Is recorded when the sharp faces of the dislocated tooth with pulpal involvement or fragments have caused traumatic ulceration of the surrounding tissue. Example, tongue and buccal mucosa. Here we can see the buccal mucosa is traumatized due to ulcerations. Fistula, capital M, F by lowercase f. Fistula is scored when a pus releasing sinus tract related to a tooth with pulpal involvement is present. Here we can see the pus formation. Abscess is scored when a pus containing swelling related to a tooth with pulpal involvement is present. The PUFA uppercase by lowercase score per person is calculated in the same cumulative way as the DMFT and represent the number of teeth that made with the uppercase PUFA and lowercase diagnostic criteria. The PUFA for permanent teeth and PUFA for primary teeth are reported separately. Thus, for an individual person, the score can range from 0 to 20, lowercase PUFA for the primary dentition, and 0 to 32, PUFA for the primary dentition, as the number of primary teeth are 20, A, B, C, D, E, and for permanent teeth, it has 32. The prevalence of PUFA is calculated as percentage of the population with the PUFA score of 1 or more. The PUFA experience for population is computed as a mean figure and can therefore have decimal values. For untreated caries, it is calculated as uppercase PUFA plus lowercase PUFA by decade plus uppercase decade plus lowercase decade into 100. So caries assessment spectrum and treatment index CAST given by Joe E. Franken in 2011 to assess decade status of tooth. We have ICDS-2 score, caries involving dentine, and for caries involvement pulp and surrounding tissues, we have PUFA index, but the scores are given separately for the individual. To find it reliable, pragmatic, cohesive, and easy to read, the results obtained for ICDS-2 and PUFA led to the creation of the new index called CAST index. Spectrum, complete range of situation going from one extreme to its opposite to record the continuum in stages of carious lesion progression from early demineralized area in enamel of infections of pulp and its surrounding tissues, combination of ICDS-2 and PUFA index. It also records the presence of restorations and teeth loss due to caries by including M and F missing and filled components of DMFT index. CAST minus ICDS-2 plus PUFA plus M and F components of DMFT indices. Stages of non-caries stages, state of caries involving enamel, dentin, pulp, and surrounding tissue, along with tooth loss due to decay and teeth which are restored can be known. So this is the characteristic code and description of CAST index. So we have 0 for sound, 1 for sealed, 2 for restored, 3 enamel, distinct visual change in enamel, 4 for dentine, internal caries related discoloration in dentine, we can see here, and the lesion appear as a shadow of discolored dentine visible through enamel, which may or may not exhibit a visible localized breakdown. Here we can see in 5, distinct cavity in dentine, no expected pulpal involvement is present. In 6, we have involvement of pulp chamber, distinct cavitation reaching the pulp chamber or only tooth fragments are present. 7, we have abscess fistula, a pus containing swelling or a pus releasing sinus tract related to a tooth with pulpal involvement due to dental caries is present. 8, may lost, the tooth has been removed due to dental caries, and other in 9 does not match with any of the other categories. So advantages: useful for analysis of dental caries in public oral health setting. It reports the consequences of untreated ones, ulcerations, fistulas, etc. Even missing and filled tooth can be identified and has become an important epidemiological tool. Disadvantages: active and inactive stages of enamel caries lesions are not taken in cast index. Now, the conclusion: indices are used for detection, diagnosis, and assessment of various diseases, and even the prevalence rate of individual and the also population can be known, which will help in any epidemiological investigations so that the effective measures can be taken. They are easy to use and help us to know the severity of the disease. These are the references. Thank you.